No, this is on my. Hello, can you hear me? Hello.
Hi, ma'am. Yes, we can hear you.
Okay, so I will start. Can you see my slides?
Yes, ma'am.
Okay, I'll just start the slideshow. Is it full screen for you?
Your
Hello.
voice is not clear, madam.
Yes, ma'am.
Okay. So okay. So I started sharing the slides. So my topic is IUI protocols. So IUI is an ART, artificial reproductive technology, where processed sperms are placed inside the woman's uterus using a catheter, aiming to increase the chances of fertilization by bringing sperms closer to the egg in the fallopian tube. It is usually commonly used first line treatment for various types of infertility, including male factor, unexplained, and ovulatory disorders. It can be performed using a partner sperm or donor sperm. It is cost effective, and it is cost effective in properly selected group of patients. Success rate: a younger woman less than 35 years, it can be 15 to 25%. Between 35 to 40 years, it can be 7 to 12%. More than 40 years, it will be 2 to 5%. So indications for IUI: female factor, male factor, donor sperm indication, and others. Female factor, mainly ovulatory disorders, anatomic defect of the vagina or cervix, hostile cervical mucus, sexual dysfunction, and minimal to mild endometriosis. Male factor can be anatomic defects of the penis like hypospadias, ejaculatory dysfunction, retrograde ejaculation, or male subfertility. Donor sperm: oligospermia, asthenospermia, necrospermia, azoospermia, or history of orchidectomy, chemical or radiation exposure, again leading to azoospermia. These can be the donor sperm indication. Other indications are unexplained infertility, poor postcoital test, combined subfertility factors, serodiscordant couple. If husband is positive for any serological condition like HIV and HBsAg, couple may opt for IUI. Waiting for IVF or not affording for IVF. So these are the indications. So prerequisites for IUI are: at least one tube should be patent, documented either on HSG, because it can be reproduced, or on diagnostic laparoscopy, or on HICO-C or such tests which are reproducible. It can also be demonstrated on SSG, but it is operator dependent. So preferably HSG or laparoscopy, where there can be documentation present. And the sperm parameters should be favorable. I have put the count and motility factors in further slides. Ovulation should be documented, and endometrium should be responsive. So these are the prerequisites for IUI. So basically, it is divided into ovulation induction, follicular monitoring, trigger, semen collection and preparation, insemination, luteal phase support, some special considerations, and when to do cycle cancellation. So case selection is very important in IUI. So basically, duration of infertility and female's age are the most important factor. Patients with unexplained infertility, mild endometriosis, cervical factor, mild male factor will benefit from IUI. Then patient preparation: either it can be natural cycle IUI, but the results are seen better with stimulated cycles. The stimulation can be with either oral ovulagens or gonadotropins. Luteal support is mostly given in the form of progesterone. HCG also can be used, but with risk of OHSS. Estrogen actually is not recommended or supported in any studies. Number of IUI: it should be one or double IUI. All these factors will also affect the success. Then IUI can be done, actually it is intrauterine, but can be put intracervically or intraperitoneally, or sometimes cap insemination can also be done. Timing of IUI based on the ovulation, usually 32 to 36 hours post trigger. Then the semen sample is prepared either by swim up or density gradient or simple wash. So these are the different distinct. So good results are usually noted in anovulatory infertility, cervical factor infertility, unexplained infertility, or donor IUI, and in younger women. Poor results are noted with severe male factor infertility, tubal factor, pelvic adhesion, severe endometriosis, and older women with lower egg reserve. So prognostic factors for success of IUI, most important is women's age, duration of infertility, stimulation protocol, infertility etiology, number of cycles, timing of insemination technique, number of pre-ovulatory follicles, and semen quality. So patient selection and workup, assess ovulation status by follicular study, tubal status by HSG, hormonal status by prolactin and TSH, because they will affect the ovulation. Patients with high prolactin will have luteal phase, like unruptured, luteinized unruptured follicle, and also luteal phase defects. So the ovulation induction, before we start the ovulation induction, you have to make sure that these hormones are under control, prolactin and TSH. Semen report count should be more than 10 million per ml in the post-wash semen sample. Exclude fibroids or any intracavitary pathology like polyps or adhesions. Tuberculosis, hydrosalpinx, severe endometriosis also should be excluded. Usually we screen for viral markers, VDRL, HIV, HBsAg, and HCV. Blood sugar and serum insulin also can be checked for severe PCO. Both partners must be screened for infections, and thyroid and sugar. That is about the workup. So these are the semen parameters. Semen concentration more than 16 million per ml, progressive motility more than 30%. So these are the requirements. So ovulation induction, the aim of ovulation induction in IUI is to develop 2 to 4 mature follicles. So it can either be done with oral ovulations or it can be done with gonadotropins. Usually we start with oral ovulations for younger women. Clomiphene citrate was the drug of choice until few years ago. It is an anti-estrogen, but it has a negative effect on cervical mucus and endometrium. So clomiphene citrate is not preferred nowadays. Now the first line of treatment is letrozole, which is an aromatase inhibitor, and it prevents conversion of androgen to estrogen, causing reduced level of estrogen, and this triggers the release of more FSH from pituitary gland, promoting follicular growth. So low A2 in initial follicular phase, receptor upregulation is the mechanism of action for letrozole, which also results in better endometrial dating and implantation window. Another drug which can be used is tamoxifen. Gonadotropins like HMG and FSH both can be used. So ovulation induction, usually we start from second or third day of menses. Letrozole 2.5 milligram BD for 5 days can be given at higher dose of 5 milligram BD also if there is no response to the letrozole. Those can be increased in the next cycle. Then there can be also use of extended letrozole regime for patients who are having poor response in previous cycles. So 2.5 milligram BD dose is given for 7 to 10 days in extended letrozole regime based on the response. Then based on AMH, AFC and age of the patient, we give gonadotropins like HMG or FSH. The dose is basically decided based on AMH, AFC and age. Younger women can be given lower dose. PCO, we have to be very careful about the dose. Usually we start with the lower dose and we decide about the dose in the next cycle if we should give a higher dose, because there's always a risk of OHSS. So HMG or FSH can be given as 75 international units per day for the first stimulation cycle. Late in the consequent cycles, dose can be adjusted between 75 to 225 international units. It can be started from day 2 to day 3 of the cycle for 5 days. Then we assess the response to the gonadotropins on follicular scan, mainly the number of dominant follicles which are more than 11 mm size. And there can be step up protocol which is used or step down protocol which can be used. Most commonly we use letrozole plus HMG combination. It has an advantage that even with multifollicular development, it can keep the estrogen levels under control and allows the good growth of endometrium, so that also it prevents the luteal phase defect. So step down protocol, actually step up and step down, these protocols are depicted in this picture. Step up protocol gradually increases FSH and HMG dose to find the lowest effective dose that can produce a dominant follicle, aiming to avoid complications like OHSS and multiple pregnancies. Usually it is used in unexplained infertility. So gradually, after seeing the response on follicular scan, we can increase the dose from 75 international units to 150, or sometimes even 225. But we have to keep it in mind, IUI is usually used in patients who are not sometimes not willing to go for IVF also. So the cost effectiveness might be lost if we have to use higher dose of gonadotropin. Then step down protocol, it actually the use of the gonadotropins in gradually decreasing doses, basically to reduce the risk of OHSs. This mimics the natural follicular phase, like we are starting the higher FSH dose and then we step down as the FSH level declines as the follicle grows and produces estrogen as the follicle size increases. So it is commonly used in polycystic ovary patients because we don't want OHSs, and it can also be used in patients who are higher age, women who are higher age, like advanced maternal age and previous poor response to stimulation, because we have to cross the threshold level of the follicles. So we can start with a higher dose and then we can step down based on the dominant follicles on the scan. So day 7, if we are doing a scan, we check how many dominant follicles above 11 we can see. If suppose we are seeing less than 2 follicles, you can continue giving the same dose, and once you have 2 to 4 follicles which are above 11 then you can start reducing the dose. So step up or step down, 2022 randomized trial, uh, second randomized clinical trial found that step up protocol resulted in a significantly higher clinical pregnancy rate for patients with unexplained infertility compared to step down protocol. So unexplained infertility patients may benefit with step up protocol. The same study also noted that the step up protocol led to a much lower rate of cycle cancellation due to OHSS and was more cost efficient per pregnancy. So this is for unexplained, but for PCO patients, usually we don't prefer a step up because with increasing dose, sometimes the patients may respond late and with more number of follicles resulting into OHSs. So polycystic ovary patients, we don't prefer using step up protocol. So now this is a review of evidence supporting IUI recommendation. So recommendations through assessment of develop PICO questions. This clomiphene citrate or tamoxifen are acceptable alternatives to low dose gonadotropins for low multiple pregnancy and birth rates and with lesser cost, although at a lower live birth rate than with gonadotropins. So basically, gonadotropins have higher live birth rates. So if we have to choose between the drugs, first line is letrozole, because nowadays we are not using CC as I already mentioned. But along with letrozole, if we want to use gonadotropins, the live birth rate might have shown in the study that it is more. So addition of GnRH agonist, because sometimes if there is asynchrony between the growing dominant follicle and endometrium, like endometrial thickness is lagging behind, then sometimes doctors tend to add an GnRH antagonist or to give time for endometrium to grow. So basically those things are also not recommended. Addition of GnRH agonist to gonadotropin in IUI or ovulation stimulation is not recommended because there is no increase in pregnancy rate despite increased multiple pregnancy rate and increased cost. So good practice point is an alternative to cycle cancellation. This is about IVF. Aspiration of excess follicles at the time of HCG or LH search might be additional option for reducing risk of multiple pregnancy. So basically this I've kept only to show that clomiphene citrate or tamoxifen can also be used as an alternative. Now coming to the Siemens sample collection. One second, trigger slide is missing. So trigger is actually, we decide the trigger based on the lead follicle size. So how many follicles are above 18 and once they reach 18 or above size, then we can decide about the trigger, and endometrial thickness 7 or more. usually we see. So ovulation typically occurs 24 to 36 hours after trigger, usually 32 to 36 hours. But once we give the trigger, we do the scan immediately next day also. So after trigger, next day, if it is ovulated, we do the IUI on the same day, or we check again after 36 hours. So HCG is commonly used for trigger of 10,000 international units. So follicular monitoring scans, serial scans to monitor follicle growth are done from first scan is day 2 or day 3 to check the antral follicle count, if any cyst or dominant follicle is there. Also, if any cyst is present or dominant follicle, we can check the estradiol level to decide to cancel that cycle, or we can go ahead with the stimulation. Then based on the number and size of the follicles, we decide the dose of the injections, gonadotropins or letrozole. Then endometrial thickness and blood flow also is monitored during the follicular monitoring scan. 3D ultrasound is also done to rule out polyp or adhesions when the lining has crossed at least 6 millimeters. On trigger day, we check the color Doppler of the dominant follicle, and even the endometrial lining, we check the color Doppler. So for endometrial thickness, good thickness is 7 mm or above, and the vascularity up to more than grade 3 is considered as good vascularity. For the dominant follicle, we check the vascularity around the follicle, perifollicular vascularity. If it is taking more than 75% of the circumference, the color, then it is considered good to trigger. RI and PI values of the follicular vessels are also checked. So RI values between 0.4 and 0.48 and PI values around 1.9 to 1.94 are considered good to trigger. So this is about the trigger. I think the slides have become... 1 second. Semen sample collection. So sample is collected in the premises, preferably. If home collected sample is used, then it should reach the clinic within 20 to 30 minutes. If we are using home collected sample, then we must ask for the consent for home collection from the patient, stating that it is their own sample, and the clinic will not be responsible for any mismatch. If collection difficulty is expected, then we freeze the semen sample before the start of IUI cycle. Difficulty in sample collection on the day of IUI, then we may give some medications like sildenafil for helping the ejaculation, and we may also advise the use of vibrator in cases of difficulties. So volume of sample which is after preparation is around 0.5 to 0.3 ml. Count should be more than 16 ml, and total motile sperm concentration post wash should be more than 10 million for a good success rate. So IUI is performed with the patient in the dorsal lithotomy position on an half-filled bladder. Cuspospeculum is inserted, the cervical os is identified, and cervix is cleaned with a swab of sterile saline. Antiseptic solutions like betadine are not used for cleaning. Meanwhile, in the laboratory, an atraumatic Wallace ET catheter or IUI catheter is loaded with 0.3 to 0.5 ml of processed semen sample. The catheter is inserted into the uterine cavity without touching the fundus, and the sperm suspension is gradually released. This is done under ultrasound guidance with patients having full bladder, so that we can have a window for viewing the uterus. The patient is advised to rest in the same position for 15 to 20 minutes prior to discharge. So this is about the collection of the sample to intrauterine insemination time interval. The processing of semen specimen must be done just after liquefaction within 30 minutes of collection, and IUI is to be performed immediately after processing and within 90 minutes of collection. The prolonged incubation impairs the sperm parameters. So IUI should be performed within 90 minutes of collection. The effect of IUI time on semen parameters, there is this study which shows the effect of time to success of IUI. This is also, I think, okay, this is done. So there are different methods of semen sample preparation: simple wash, swim up, or density gradient. Different patients, we use different methods. So this is based on the if the patient is seropositive, or if the patient is having any like low motility, which methods to use. So I'm not going into those details. So insemination, before insemination, we have to make sure that signs of ovulation are seen on the scan. These are reduction in the size of the dominant follicle, or presence of corpus luteum, free fluid in POD, or luteinized endometrium, which looks homogeneous and compacted. After documenting ovulation on scan, we check the consents, semen sample collection is done, patient is prepared, and then we put the IUI sample into the uterus. So there is, I have not included another thing is luteinized unruptured follicle. Suppose if the signs of ovulation are not seen clearly on the ultrasound, like if the size is not decreased properly, or it looks more like a hemorrhagic cyst and there is no free fluid in the POD, then it can be luteinized unruptured follicle. In such patients, on the next cycle, when we prepare for IUI, for the triggering, what we do is we can give double trigger, and also we can give GCSF injection once the follicle crosses 16 mm of size, so that the vascularity of the follicle is improved. And in patients who have luteinized unruptured follicle, we have to rule out mainly hyperprolactinemia if she is using any drugs which may lead to increased prolactin levels, or if she has used any NSAIDs around the time of ovulation. So you have to instruct the patients not to take painkillers around the time of ovulation. And luteinized unruptured follicle is also commonly seen in endometriosis and patients with pelvic adhesions. Now about the LPS in IUI cycles. So why do we... Hello? So this luteal phase support, why do we need in IUI cycles? So what happens in IUI cycles is, because we try to grow more than one follicle, 2 to 4 follicles, there are supraphysiological levels of estrogen. So these supraphysiological level of estrogen interferes with proper functioning of the HPO axis and causes corpus luteum dysfunction. It causes drop in the LH level, and it causes the corpus luteum dysfunction. So elevated estradiol during the follicular phase and progesterone in the early days of luteal phase impair LH secretion during the luteal phase. In ovulation stimulation, estradiol commonly reaches and exceeds by tenfold the values encountered in menstrual cycle. Likewise, progesterone levels produced by multiple corpus luteums under the influence of triggering dose of HCG greatly exceeds the level of normally encountered in the menstrual cycle during the early days of luteal phase. The result of these hormonal alterations in that is that corpus luteal support by pituitary LH is compromised. Therefore, this ovulation stimulation per se constitutes an indication for LPS. So that is the reason why we add luteal phase support in IUI cycles. So LPD prevalence, other than this, the our drugs which is causing LPS, LPD prevalence is also 3 to 20% in infertile women, that is luteal phase. If hello? Okay. So why do we need LPS in OI-IUI cycle? Because we are only inducing the luteal phase deficiency. But other than that, also there is an LPD prevalence which is 3 to 20% in women with infertility and 5 to 60% women with RPL. So it is a wide range of prevalence, but still to give the benefit of doubt of LPD, also we should add luteal phase support in cycles with... My slide is not going ahead. Okay. IUI. So role of LPS in IUI cycle, what does the literature say? A review article concluded that it appears beneficial to support the luteal phase of IUI cycles with gonadotropins. So when we are using gonadotropins in IUI, LPS is beneficial when more than one follicles are there and like more than one eggs are released. So double-blinded RCT shows that LPS with progesterone did not improve outcome in IUI cycles with CC or HMG. Benefit most evident with gonadotropin stimulated IUI, more LBR. Typically, vaginal micronized progesterone 200 milligram BD from 2 to 3 days post IUI is what is started as LPS. But conflicting evidence because the double blinded RCT did not show the benefit. Still, like as I already mentioned, we are inducing luteal phase deficiency, and also the prevalence of LPD can be higher in patients with infertility and recurrent pregnancy loss. We add luteal phase support. So it is progesterone. Progesterone directly supports the endometrial development, provides block to the uterine musculature, thus relaxes it. It prevents alloimmunity and rejection of fetus. Vaginal micronized progesterone is usually used for luteal phase support in the dose of 200 to 400 micrograms per day, or in the form of progesterone gel 8%, 90 milligrams daily. Another option can be oral dydrogesterone if some women are allergic to any vaginal preparation, because these are oily preparation, can cause irritation, itching, and redness of the vagina and vulva. So such women, if you don't want to use vaginal micronized progesterone, dydrogesterone also can be used orally. And it is in the dose of 20 to 30 milligram per day in three divided doses. HCG can also be used as luteal phase support because there is active corpus luteum. It will help the corpus luteal activity, but there is risk of OHSS if more than two follicles have been released. Then we don't usually prefer giving HCG, though the risk is less. We, in such cases, we don't give HCG. With single corpus luteum or two corpus lutei, we can add HCG as an additional luteal phase support in the dose of 500 international unit weekly once. And LPS usually we continue till 8 weeks of pregnancy, even in IUI. Those studies don't support LPS in once the pregnancy is confirmed. We still wait till 8 weeks of pregnancy until the this luteal function is established. So now coming to the other factors, double versus single IUI. So this is a latest Cochrane 2021, which says that no significant difference in live birth rate between single and double IUI, with the evidence quality being low for live birth rate, clinical pregnancy rate, and miscarriage rate, and uncertain for ectopic pregnancy rate. While out of these Cochrane analysis, the many studies which they had included, some analysis showed a trend towards benefit with double IUI for clinical pregnancy rate. This was not statistically significant and should be interpreted cautiously due to the low quality of evidence. So based on this, if some patient insists for double IUI, we can give them a chance for this benefit, that they can consider going for double IUI. So when we are doing double IUI, usually we do first IUI on the day next of the trigger. So if we are giving trigger today, next day we do an IUI. Second IUI we do after documentation of ovulation. So this is double IUI. Now to ensure the success, what all things we look for? We check the ovarian reserve. Usually good reserve younger women will have higher success. Tubal patency should be checked. Sperm analysis, count more than 16 million, motility more than 30%, total motile sperm count in the prepared semen sample more than 10 million will have higher success rate. Optimize ovulation protocol, which means we may try to grow 2 to 4 follicles and then adequately also support in the luteal phase with the progesterone. Proper sperm preparation with, as I already mentioned, more than 10 million total motile sperm count. Use of soft catheter, doing the gentle procedure. Ultrasound guidance with partially full bladder in difficult IUIs. So the studies usually have this for IVF, that ultrasounded guided ETs have higher success rate and higher clinical pregnancy rates and all. There is no such studies which say that it is better, but usually we do it under ultrasound guidance so that we make sure, and also we show to the patient on screen that how we are putting the sample, it is going inside the uterus. And if any difficulty in negotiating the track, the ultrasound guidance will help us. So in such cases where we are having difficulty in passing the IUI catheters, we sometimes use the embryo transfer catheter because they are smaller than the IUI catheter and they are more firm. Like if we are using the hard catheter of ET, then they are more firm than the IUI catheter, and they don't get bent when we are trying to negotiate through the difficult track. And also plan whether single or double IUI in advance, so patient can be financially also prepared and can come. Husband also has to come twice to give the semen sample, and release the sperm slowly. Ensure there is no backflow. These are the tips for the IUI. Then this is just about the basic setup for the IUI: macular chambel, manual cell counter, microscope, centrifuge, laminar flow workstation, test tube warmer, dry incubator. These are the disposable. The centrifugation tubes for semen sample, semen collection containers, then the pipettes, and also the IUI catheter. And after preparing the semen, they put it in the IUI tube, the small tubes, before loading it into the IUI catheter. And to load, again, we need a small syringe, 1 cc syringe, BD syringe. So coming to the IUI cycle cancellation. So how to when to cancel the IUI cycles, and also to reduce the risk of OHSS. Usually IUI cycle is cancelled if there is no response to the stimulation, like there is no follicular growth. Then what we do usually is, suppose even after giving gonadotropins, there is no response to the stimulation, like all the follicles are small, less than 8 mm or less than 10 mm basically, then we check for the estradiol levels. If estradiol levels are less than 50 mg still, then you may consider, usually this happens in PCO patient, you may consider increasing the dose of gonadotropin. If the estradiol levels are more than 50 mg, then we cancel the cycle, and we ask the patient to come on the next cycle, and we may start with higher dose. So this is about no response is one reason for cancellation. Second reason for cancellation is OHSS, ovarian hyperstimulation syndrome. So when we cancel cycle for OHSS, so when we monitor the follicles and estradiol levels, if the less than 3 follicles, more than 14 mm, and E2 is less than 800 picogram, then we can still proceed with HCG trigger and IUI. If there are 3 to 4 follicles, more than 14 mm, estradiol levels 800 to 1200 picogram per ml, then there is a borderline risk of OHSS. So we have to counsel the patient accordingly and decide if the patient is willing to take little risk of OHSS, then we can proceed with close monitoring. Even after IUI, about the symptoms of OHSS, we have to sensitize the patient that like she may feel bloating or breathlessness or difficulty in breathing. All those symptoms we have to explain, and then we can go ahead with the trigger and IUI. If there are more than 3 follicles, more than 14 mm on day 8 or day 9, or more than 6 follicles, more than 11 mm, then also you can consider. But usually we can 11 mm follicle size, we can wait and see without adding any extra dosage. But more than 14 mm 3 follicles, we have to consider that there might be risk of OHSS. Estradiol levels more than 1200 to 2000, then we counsel for risk of OHSS and multiple gestation, and we may cancel the cycle and withhold the HCG injection. So usually up to 4 follicles, practically we do go ahead with the trigger and IUI. But theoretically, more than 3 follicles, more than 14 mm, we may have to consider cycle cancellation. So what we do for cycle cancellation is we give them cabergoline 0.5 mg vaginally once daily for 6 to 7 days, along with progesterone like meparate, and that usually takes care. We ask them to come for scan after 1 week, just to check if she has already ovulated and if there is any fluid or she is symptomatic. Otherwise, like if there are no symptoms and if the scan is okay, they can directly come on day 2. So this was about the IUI. Thank you. Any questions? So if somebody has any questions, I will answer the questions.
Hello, ma'am. This is Dr. Sumalata from Nirmal.
Yeah, tell me.
Am I audible? Ma'am, can you just repeat the cancellation of the cycle part?
Oh, I stopped sharing 1 second. So basically, on day 6, if the follicles are more than 11 mm, 6 follicles,
Yeah.
or on day 8 or day 9, if we are seeing 14 more than 14 mm, 3 follicles, or estradiol level 800 to 1200, more than 800 to 1200, then we can theoretically this is what is given, but usually up to 4 follicles we do go ahead with trigger and IUI. If there is no free fluid, we take a judgment on the day of trigger. If there is already any pre-existing free fluid, then we will not proceed. But if there is no free fluid and 4 follicles are there, then we clinically still go ahead with IUI. We do explain to the patient about OHSS risk, but we go ahead with IUI.
So we will give cabergoline 0.5 mg daily for 7 days, ma'am. Vaginal?
Vaginally, yes.
Okay, ma'am.
And
Thank
we
you.
also give like meprate, progesterone. So because progesterone will also suppress the HPO axis, will reduce the LH secretion and FSH secretion. So we also give meprate along with that, and
Yeah.
we counsel the patient not to have intercourse also to prevent any accidental rupture of follicles and pregnancies.
Meprate, how long, madam?
Okay.
Same 1 week to 10 days?
Around 10 days we give.
That OD, madam? 10 mg OD like that?
10 mg OD, yes.
Okay.
Okay, ma'am. Thank you.
Okay. Any other question?
Ma'am, can you please explain the physiology of luteal phase defect, ma'am, because of these ovulation inductions?
So basically, when we are giving 1 second, I will just try to see if I can. Can you see? No. Is it visible again, the slides? Can you hear me?
Yes,
Hello?
ma'am.
Yeah,
Yes,
yeah. नहीं कुछ नहीं बंद मतलब I had stopped sharing, so I wanted. हो गया. Okay. Can you see the slide why LPS in OI and IUI cycles?
Yes, ma'am.
I'm just making it full screen. So basically, because we are trying to grow more than 1 follicle, like if we are aiming to grow 2 to 4 follicles, the estradiol will be coming from all these follicles. So this supraphysiological level of estrogen, it interferes with proper functioning of the HPO axis, and it causes corpus luteal dysfunction. Elevated estrogen basically and progesterone in the early days of luteal phase impair LH secretion during the luteal phase. To maintain the corpus luteum, we need LH secretion, which is maintained, and there is also something called as luteal gap. So after ovulation, there is a luteal gap, and because of this LPD, which is created because of our stimulation, that luteal gap can be profound. So this is the reason why we need luteal phase support.
Okay, ma'am.
Okay, ma'am.
And also infertile patients, like as I mentioned in the same slide, that prevalence of luteal phase defect is also 3 to 20% in infertility women and 5 to 60% in women with recurrent pregnancy loss. So this is also a reason, and plus we are creating a luteal phase defect by our supraphysiological estrogen.
Ma'am, what is that cap insemination, ma'am?
And that day actually they put a cap over the vagina after putting the semen sample. So, but nobody practices it routinely. They used to do that. I actually didn't want to show all those things. Only few points of that slide was important, but it is mentioned in that after putting the IUI sample, just to make sure that it remains inside the uterus, there were some like silicone cap like things which were available, which they used to put it on the cervix for some time.
Okay. Thank you, ma'am.
Ma'am, can you just summarize the IUI procedure, not only the day of procedure that we do, like from stimulation, at what days we call for follicular study and then trigger and then IUI. Can you just summarize that?
So like follicular monitoring sheet kind of thing you want?
Yes, ma'am. Like ovulation induction, we start with latrose and gonadotrophins, from day two and all. If it is other than PCO, like we go with step up protocol and we call her on day 9, ma'am. Like day 9, we see the
If
follicle.
usually we start from day 2 or day 3, and
Yes,
we
ma'am.
give, or like if we are giving letrozole, we give it for 5 days,
Yes,
and then
ma'am.
we see it on 6th or 7th day.
Yes,
So
ma'am.
6th, 7th day, some of the patients will have a dominant follicle, some still may not have. So
Yes.
if the 6th day itself, if I'm having dominant follicle more than 10 mm, then we have to see how many dominant follicles are there. So
Yes,
if
ma'am.
the dominant follicle is only one and you want more follicles, then you may add HMG on that day itself,
Yes,
and
ma'am.
daily 75 international units if it is her first cycle. If it is a repeat cycle, then we need to decide the dosage based on the response of the previous cycle.
Okay, ma'am.
So usually even with this letrozole, even if we say monofollicular development, we clinically we see sometimes multifollicular development also. So first scan will be on 6th day.
Yes,
Then
ma'am.
after that, how the follicle size is and the endometrial thickness, then we decide. Also, I did not add in the presentation about addition of any agents or estrogen for endometrial growth. Usually we tend to we tend to take overaction for endometrial thickness, but
Yes.
that is not required. Usually the estrogen levels will rise once the follicle crosses 14-15 mm,
Yes,
so that
ma'am.
you can wait for the follicle to grow at least 14-15 mm and see how the lining thickness is. If the patient has suppose previous cycles with lower side endometrial thickness in natural cycle monitoring or OI monitoring, then you may consider adding other agents like elarginin or sildenafil for
Yes.
improving the vascularity. But estrogen, usually we don't add uh, until we have at least one cycle documented, even after like around time of trigger also. If the ET is less than 6 mm, then you may consider adding estrogen in the next cycle. Usually ET will pick up once the follicle is near ovulation, like 17 once it crosses 17-18 mm, it will increase. And if
Yes.
we adding estrogen, then we should also continue estrogen even in the luteal phase support. You should not stop estrogen then.
Okay, ma'am.
So preferably we don't add estrogen, because also estrogen will prevent estrogen will prevent the natural follicular growth also, because we are adding it from outside. So that is one thing. And like other agents or even the body will show the response when the endogenous estrogen levels will rise after it crosses 17-18 mm.
Yes, ma'am. So
So
the yes,
after
ma'am. Please continue.
So after day 6, based on the endometrial thickness and the number of follicles and size of follicles, what we do is we give the patient the next date. So if the follicles are like suppose around 9-10 mm, then we expect up to 14 mm. It might be 1 mm growth per day, 1 mm of the size. So
Okay.
accordingly, we call the patients after 3 days or 2 days,
Yes.
and we see if the endometrium is also responding along with the follicles. If the endometrium is lagging behind too much, then as I said, we add elarginin and sildenafil. If it is growing okay, then you may call after 3 days also. And like I've not mentioned, but we advise patients to have intercourse once the follicle crosses 17 mm. We don't advise any abstinence period, because we will be selecting only patients who have a sperm count of more than 16 million and motility more than 30% for IUI. So
Yes.
there should not be any problem with the semen count or motility at the time of IUI. So after 6th day, based on the growth, we decide. Also the dosage we will decide based on the number and size of follicles.
Yes, ma'am.
More than 10 mm, if they are growing continuously 2 to 3 follicles after 3 days also, then we need not add anything.
Yes.
But up to 14 you may have to consider adding an HMG if there is asynchrony in the follicle size. Suppose one follicle is 12 but the other follicle is like 9 then you may consider adding an HMG also till both the follicles cross 14
Okay, ma'am.
Once they cross 14 usually they will continue growing.
Yes, ma'am.
Can consider giving HMG till 14 or 15
Yes.
Then we call according to the judgment. Like after 15 the follicles will grow 2 millimeters per day. So around 18 if I want to trigger, then I will call her accordingly based on calculation, like when the follicle will become around 18 or more. Then on that day, we explain about the trigger to the patient. And after the trigger, next day also we call the patient for a scan.
Yes, ma'am.
Just because we are not adding an antagon, we are not checking the hormone levels. Suppose
Yes,
if
ma'am.
it is already ovulating because LH surge has already started, then we may miss that time. So we call on the next day of trigger also.
Yes, ma'am.
And we call again, like if it is not ovulated, we again check at 36 hours.
Okay. After ovulation, we do the insemination.
Yes.
Like explain. Yes, ma'am. Thank you, ma'am. Thank you so much.
Welcome. Any other question?
As of now, nothing extra.
Is in the chat. I don't know. 1 second. Please, ma'am, keep no nothing. No question. Okay. Okay. Thank you.
Thank you.